So this is part 3 of the principles of electricity, and this will be the final part before we dive deep into the specific types of electrical modalities that are on the market and that you guys can use to kind of cause physiological changes within the patient. You guys can tell that knowing the background before actually applying is extremely important if I'm spending 3 online lecture series just getting us to this point. So this shouldn't take long, but let's talk about the goals of the treatment. When you're applying electrical modality, what should you be considering? The first thing is, what level do you want to stimulate that patient to? In other words, what physiological changes do you actually want to see, right? So there are 4 different levels that we could aspire to stimulate to. The first one is what's called subsensory. So essentially what we think about with subsensory is, as the name implies, it's before they actually feel it. So essentially what we're going to say is, this is when you're ramping it up and you go, tell me when you can feel it, tell me when you can feel it. It's exactly the point at which the patient can feel it back down 1, right? So in a subsensory treatment, we don't want the patient to feel it. It's subsensory for a reason, right? Most often we use this in microcurrent. It's a subsensory treatment. And it's utilized a lot to help with tissue healing, in some instances fracture healing as well. So subsensory, patient first feeling the electrical stimulation, and then we back down from that so that they don't feel the electrical stimulation at all. We have a sensory type of stimulation, which is the point at which we see a slight muscle twitch. So this isn't about the patient feeling it. We're looking at the patient as we're pressing that intensity, and then once we see the muscle twitch, we're going to reduce that intensity by 10%, right? So if the intensity is like, I don't know, 20, then we're going to reduce it to 18, right? And that's sensory. And the goal of sensory most often is going to be to trigger the A beta and to trigger it to close the gate to pain so that we can reduce pain. So most often sensory level stimulation is going to be used when we're trying to reduce pain, okay? The motor level stimulus is the one that we most often use. This is where we want to ramp up the electrical stimulation until we see a muscle contraction, and we're actually going to cause a little bit of pain with that contraction. Because if the goal is to, number 1, cause depolarization of the motor unit and to regain muscle strength, yes, there has to be a little bit of pain associated with a muscle re-education type of electrical stimulation. So not only do we want to see the muscle contraction, but we want to go until the patient feels pain. Now, some of you are extremists, so you're going to say, like, what scale of pain? Like a 1 or a 2. But we want the visible muscle contraction, and we want the patient to experience a little pain because we know that that muscle and the motor unit that's supplying it is working relatively hard. But when we get to muscle re-education, you'll see that we don't do a whole bunch of exercises, or we don't spend a whole bunch of time using this type of stimulation, because number 1, the muscle's going to get fatigued, but number 2, the patient's going to be experiencing a little bit of pain, right? The last type of noxious stimulation, is noxious stimulation. So in other words, we actually want to stimulate the pain fibers. And remember, I already talked about this, where we want to actually, the central biasing theory, where we want to actually replicate the pain in hopes that replicating the pain will allow the patient to live through the painful event, right? So sometimes we do that. I've never done it in the clinical setting, but we've seen it a lot in in our veterans who've lost limbs, things like that, where we want to kind of replicate the pain so they can learn how to live with it. But again, in the clinical setting, very, very rare. So these are the 3 different types of stimulation levels that one can use when treating. Certainly I've just seen clinicians go, oh, tell me when you feel it, and there's no slight muscle twitch, right? They just leave them to go. But I'm telling you, the ideal would be in a sensory where we're really, truly trying to reduce or trigger the A beta to fire. We want that slight muscle twitch to be seen, and we want to reduce it by 10% to truly get that sensory level stimulation. So we want to avoid accommodation during the treatment, because if the patient experiences accommodation, then what we know is, number 1, we aren't triggering depolarization anymore. And number 2, we are not going to see the physiological response that we hope to see in the treatment. So we want to avoid it during treatment. So in order to do that, we want to make sure that the stimulus is enough to cause depolarization, right? Remember the action potential that needs to be triggered to cause the depolarization. And so what we'll do is we'll increase the intensity of the treatment most often And so my question here is, what do we need to do? Most often we increase the intensity, or the better way to do it instead of continuing to increase the intensity is to create a ramp, to establish a ramp so that the frequency spans through a number of frequencies. So 80 to 100, 80 to 150. And then what we know about this is that the nerve does not accommodate, right? And so then it will require less of a stimulus to cause depolarization. So this is an important concept. When you're in the clinical setting, go ahead and take a look at your devices and see if there's actually a ramp time. What am I thinking? Oh, a ramp time parameter on the actual machine. If there isn't a ramp, then you have to adjust it by making the frequency span. Either way, you can adjust. Okay. So remember I said sometimes phase duration and pulse duration are used synonymously. And so now I'm going to tell you when they are and when they aren't, because I think it's important characteristics that you have to understand. In a monophasic wave, right, one that does not cross the isoelectric line, the pulse duration and the phase duration are one in the same. Does that make sense? We can see that this will represent the amplitude of the treatment. So far, so good. So same thing. This is the pulse duration. This is the phase duration. They are the same. This is the pulse duration and the phase duration. They are the same, right? Now, we're going to move to more complex waveforms where they are not the same, okay? So in our alternating and biphasic currents, particularly biphasic where we're using muscle re-education electrical stimulation devices, this will be key. So I want to be clear here because students always miss this on the exam. When we are referring to an alternating or biphasic current, the pulse duration and the phase duration are not the same. The pulse duration represents the amount of time it takes the wave to complete its cycle. So the time it takes to go from the bottom of the isoelectric line to the top and then end, right? So this is the entire pulse duration, the amount of time it takes the biphasic wave to complete one wave, right? One wave. Does everybody see that? These are all actually, yeah, alternating currents. But you get my point, right, guys? You can see this, the pulse duration is the entire time it takes the wave to finish. In an alternating or biphasic current, the phase duration is something different. It's the amount of time that it takes the pulse to complete its cycle on one side of the isoelectric line. Does that make sense? So if we're looking at this particular wave, this part of the wave, this is its phase duration. And then this part, the dotted part of the wave, this is its phase duration. Does that make sense, guys? And we can tell in these instances that they aren't the same, right? Maybe to the human eye. If we go here, it becomes even clearer. The amount of time it takes the entire electrical stimulation or current to finish its entire cycle, that's the pulse duration. And the phase duration represents the amount of time it takes to complete on one side of the isoelectric line. So this is the phase duration for the solid part. And this long phase duration represents the phase duration for the dotted part of the wave. So we can see how when we're dealing with alternating currents, the phase duration and the pulse duration are not the same. So I'm going to ask this question, and I'm sure I'll ask it later too. Which of these, pulse duration or phase duration, would we manipulate if we want to cause depolarization of the motor unit? Which one do you think? If you said phase duration, you would be correct in this case, in the alternating current, biphasic current, right? If we want to trigger, listen to me, the motor unit, so we need to adjust it and make it about 200, 250 microseconds, right? What we need to adjust is the phase duration, not the pulse duration in an alternating current or biphasic current, okay? Pulse duration represents the amount of time the wave takes to complete its entire cycle, but it's the phase duration that we alter if we are trying to depolarize the motor unit, the A beta, right? This is the parameter that we are adjusting, okay? That's on the device. Most devices have it, specifically if you select biphasic. Most often I've seen it in Russian as well, okay? You can adjust the phase duration in those devices. It is not the pulse duration in an alternating current or biphasic current, right? Again, I'm going to go back here and I'm going to say it doesn't matter. They're both the same, right? Because it's on one side of the isoelectric line. All right. Now we're going to add in a few other terms. So we have the intra-pulse interval, intra with an A, which means, okay, here's a pulse, and we're looking at it here. It's on, it's on, it's on, it's off. It's on, it's on, it's on, it's off, right? Now, if we're looking at the pulse period, which is a little bit different because we're dealing with a pulsed wave, then we say it's the time that the pulse turns on. Make sense? All the way until it's done with its final rest and begins to ramp up again. The intrapulse interval is the time it's off in between pulses. The interpulse interval is the time it's off before it begins a whole new set of waves. Okay? Let's look at it here as it drops into the isoelectric line. The pulse period really doesn't change, right? The time it's on till the time it begins its next phase. The interpulse interval is still the same, right? It's just the time it's off before it drops, right? The interpulse interval doesn't really change. It's still the time that it takes to finish one pulse to the time it's off to start another, right? So these are periods of off time, but it's either off time within a wave or it's off time before we begin another wave, okay? We have the pulse period. These are for waveforms that turn off at some point in time, okay? These are all important variables that you have to consider. All right, considerations when setting up the patient. Here's what we know. Further apart, we're penetrating deeper. Closer together, we're getting superficial tissue. So the first question you're going to ask yourself is what? Is the goal deep or is the goal superficial? You'll have to ask yourself that. You just have to make sure, number one, your pads are parallel to the muscles, fibers, and how far apart do you want them to be based on your target tissue. You've already seen this, so I'm not going to review it again. Then next we have the duty cycle. Most often this can refer to an internal duty cycle that the machine sets, or it could be something that you as the clinician will set. And we'll talk about it more when we get to muscle reeducation, but it's the amount of on and off time. And in muscle reeducation, remember, we're going to need that off time. Why? Because not only do we increase the intensity to muscle contraction, but what else do we do, you guys? We have their patients in pain while they're doing it. So we want the off time to reduce the contraction, turn off the contraction, but also reduce the amount of pain that the patient is actually in. So duty cycle can also reference the stimulation and rest cycle. So in other words, the amount of time the device is on. The awesome thing is that most devices are now adjustable. So you can decide how much time the stimulation is on and how much time it's off. So examples that I've seen in the clinical setting are 10-10, which means it's on 10 seconds, it's off 10 seconds. So that'd be a 1-to-1 ratio. I've seen 10-30, which is on 10 seconds, it's off 30 seconds, or a 1-to-3 ratio. And then I've seen it's on 10 seconds and it's off 50 seconds, which would be a 1-to-5 ratio. And the amount of rest you give a patient changes as they progress in the phases of healing, right? In the acute phase, if we're working on muscle re-ed, we want a longer rest period. So that 1-to-5 ratio is going to be better. And then in the, maturation phase, we want shorter rest periods, right? Because at this point in time, we're hopeful that the patient should be able to control the contraction and they don't require as much rest, right? And so I want to kind of end with this slide here. We talked about 1-to-1, which means it's on 10 seconds, it's off 10 seconds. We talked about 1-to-3, but we can talk about 1-to-2, on 10 seconds, off 20 seconds, 1-to-5, it's on 10 and it's off 50, right? Now, if we look at this is maximum force. So are they able to contract? And then what we can see over time, if we're looking at this, right, is that if we have 9 minutes of doing on off, What do we see happening? What happens to the force of a person who's in a 1-to-1? Right, at about 3 minutes, they're done. They can't produce a maximum forceful contraction, right? Which would be good in the maturation phase, but certainly in the acute phase, we don't want to fatigue them this quick, right? And so we look at 1 to 5, what do we know? Because they're allowed to rest, they're able to produce a higher percent max force contraction over time. So we want that in the acute phase because we want to set our patient up for success. We also want them to learn, right? Regain motor patterns so that they can learn how to contract, right? So all of that to say, this ends the principles of electricity. I don't know if you're celebrating, but I certainly am. Our next lecture segment will be on interferential and pre-mod stimulation. Looking forward to doing that lecture.